We are live now, ma'am.
Okay. Good evening. Good evening, everybody. I'm happy to welcome you all for the monthly webinar on behalf of IFS South Tamilnadu chapter. And we do this seminar every month during the last week of the month. Okay, last time we had Dr. Praveen Joshi from Bangalore. He spoke on management of male infertility. And Dr. Ananta Lakshmi did talk about semen analysis and DNA fragmentation's importance. We had a good attendance during that meeting as well. So Dr. Ramani is not here today with us. So I extend a warm welcome to each one of you who are with us to join this meeting. And I'm very happy that I have two young girls who are ready to, go ahead and do the webinar for us. I welcome Dr. Sharanya Manivannan from Erode. She works for Nova IVF, and Dr. Tamilnadu Naveen. She is again an infertility FRM degree holder, and she again is an infertility specialist from Trichy. So both of them will be sharing us the details about IVF and how to make an IUI, and they'll tell us how to make IUI a success event for each patient, whomever we come across. Thank you very much, and we move on to the scientific lecture. I request. Okay, I forgot about the prayer song. I'm sorry. Let's skip this time because I went again with all this. We move on to the scientific session. I want to call upon Dr. Saranya Manivannan. She did her undergraduation from Keel Park Medical College and her MD OG from Vinayaka Mission, Salem. And she has 9+ years of experience in OBG and reproductive medicine. She is a consultant at Nova IVF Erode, and she has several papers presented at national and international journals. And she's been a speaker as well in the regional and national conferences. Over to you, Charanya. Let's hear about how to make IUI a success story.
Thank you, madam, for the warm introduction. Good evening, one and all. So let's move on to the topic for today. I'm going to talk about how to prepare a patient for IUI and also how to optimize the results in IUI. So what is artificial insemination? It is placement of whole semen or processed sperm into the female reproductive tract, which permits sperm-ovum interaction in the absence of intercourse. What is IUI? It is deposition of spermatozoa in the uterus at any point above the internal os. Why is IUI? It is simple, effective, inexpensive, it can be easily done, and it can be done when IVF is inaccessible or not affordable. In 1973, Setlage et al. Showed that only 0.1% of spermatozoa placed in vagina reaches the cervical canal, and only 1 in every 14 million sperm placed in vagina reached the oviduct. So, the rationale behind IUI is to increase the gamete density at the site of fertilization and to overcome the cervical hostility. A little touch on history. When it all started was in 1678 when the first description of spermatozoa got reported. Initially, IUI was done in animals. In 1784, the first IUI delivering 3 puppies got reported. The first human intravaginal insemination was documented in a patient with hypospadias in 1770. The first official reports on human IUI came in 1943. And the first successful human pregnancy was reported in 1953, and first birth through frozen sample IUI was reported in 1964. The new milestone was reached in ART when sperm washing and sperm preparation techniques came into practice. In 1989, the first prospective control trials on IUI got published. For whom is IUI? IUI is effective in mild male subfertility with oligoacinoteratozoospermia, but with total motile sperm concentration of more than 10 million is needed for an IUI. In patients with highly viscous semen, in pyospermia, when there is delayed liquefaction, in all these 3 conditions, there will be agglutinates and aggregates where semen washing will be beneficial, and in patients with cervical factor infertility and in unexplained infertility, It is possibly effective in mild endometriosis, that is stage 1 and 2, in patients with immunological factors, in chronic anovulation. Special indications where frozen sample can be used when the husband is going to start on anti-cancer drugs or with chronic medical disorder. Donor insemination can be considered in severe male factor infertility where IVF is not affordable or cannot be done, in HIV discordant couple, in men with Y-linked genetic disorders, in cases of severe RH incompatibility. It is ineffective when there are blocked tubes, cervical stenosis, in ovarian failure, severe male factor infertility when own sperms are considered, in cases of severe endometriosis. How to optimize success in IUI? First and foremost is the selection of patient. In 2004, Weiner et al. Showed statistically significant age-related decline in pregnancy rate. As we can see, the success rate for IUI in women less than 30 years is around 14%, whereas it decreases drastically to about only 5% in women more than 40 years of age. So these are all the levels at which IUI success can be improved, which I am going to discuss one by one. And so regarding selection of patient, as I have already told, age is important. And coming to how to work up, routine blood investigation is done for both the partners. Tubal patency test is mandatory in the form of HSG or SSG. Ovarian reserve test, AMH along with AFC. This is useful in calculating the dosage when ovulation induction is considered. Basic hormonal profile, baseline TVS to rule out any other uterine anomalies or adnexal pathology, and a basic semen analysis. And coming to ovulation induction in IUI. The goal of ovulation is to therapeutically restore the release of one egg per cycle in a woman who has not been ovulating at all or not ovulating regularly. As we can see, the success in IUI is increased when ovulation induction is used, particularly when gonadotrophins are used. The success rate increases to about 17%, although it is associated with increased rate of multiple pregnancy and associated with increased risk for OHSS. Coming to ovulation induction, these are all the drugs which we commonly use for induction for IUI: clomiphene citrate, letrozole, tamoxifen, gonadotrophin with GnRH analogs, oral ovulogens along with gonadotrophins. First, we discuss about clomiphene citrate. And clomiphene citrate is a synthetic estrogen and it is a selective estrogen receptor modulator. It has estrogen antagonist action at the level of estrogen receptor in the hypothalamus and pituitary. And this blocks the negative feedback loop of estrogen, thereby increasing the FSH secretion, extending the FSH window. So more smaller follicles are rescued and it is associated with multiple follicular growth. So clomiphene citrate is usually started at a dose of 50 milligram per day, starting from day 2 to day 5 of cycle. 75% of women will ovulate with a dose of 100 milligram per day. The FDA approved dose is to a maximum of about 250 milligram per day. While using CC, we should also not forget about its anti-estrogenic action over the endometrium and the cervical mucus. So if there is asynchrony between the follicular growth and the endometrial thickness, exogenous estrogen can be added. While using exogenous estrogen, we should be aware that estrogen should be added after the selection of the dominant follicle. Otherwise, the exogenous estrogen again may suppress the dominant follicular development. And while discussing about the adverse effect of clomiphene citrate, the most important adverse effect is scintillating scotoma. So when a patient complains of blurring vision while using CC, the drug should be stopped immediately, and it is a totally reversible complication of CC. What is CC failure? It is failure to conceive within a maximum of 6 CC induced normal ovulatory cycles or 12 in normal cycles. So in such cases, we have to exclude other causes and we can try changing the treatment strategy. What is CC resistance? It is failure to ovulate with 150 milligram dose of CC in 3 cycles. So what does evidence says? If CC is used to induce ovulation, pregnancy is most likely to occur in the first 3 to 6 cycles, and therapy beyond 6 cycles is generally not recommended. Coming to the next drug, tamoxifen. Tamoxifen is a selective estrogen receptor modulator, and tamoxifen also acts as an estrogen antagonist at the level of hypothalamus. To note that tamoxifen has a weak estrogenic effect on endometrium and cervical mucus, which is beneficial in improving the thickness of the endometrium. The dosage used is between 20 to 60 milligram per day, and it is started from day 2 to day 5 of cycle. Coming to the next drug, letrozole. Letrozole is an aromatase inhibitor. The action of letrozole is at the level of the ovary, where it inhibits the aromatase enzyme, which inhibits the conversion of androgen to estrogen. So, decrease in estrogen is again going to block the negative feedback loop, thereby increasing the FSH secretion. And the benefit of letrozole is it increases the intra-ovarian androgen level. This intra-ovarian androgen is going to increase the sensitivity of the dominant developing follicle to the FSH. And once the dominant follicle starts developing, the estrogen secreted from the dominant follicle is not inhibited by letrozole. So this again activates the negative feedback loop, thereby preventing other small follicles from growing, leading to monofollicular development. So the dosage, the starting dose is usually 2.5 milligram per day, starting from day 2 to day 5 of cycle, to a maximum of 7.5 milligram per day can be used. And coming to a stair-step protocol is one where we tend to increase the dose of CC or letrozole within the same cycle. So we start with 50 mg of CC or letrozole 2.5 milligram. It is given for first 5 days, and then the follicular response is assessed after 5 days. Even after 5 days from the last pill, if there is no response, then the dosage can be increased. For CC, it is 100 milligram. For letrozole, it is 5 milligram. Then again, the follicular response is reassessed after 5 days. Again, if there is no response, it can be increased to the maximum dose. That is for CC, it is 150, and letrozole, it is 7.5. So what does studies say? Says ovulation and pregnancy rates are similar in stair-step protocol with letrozole and clomiphene citrate, but the time to ovulation is shorter in case of letrozole. Coming to the gonadotropin, both recombinant FSH or human HMG can be used. The starting dosage is usually between 75 to 150, and for IUI cycles, we rarely use dose beyond 150, and we most commonly use the low dose step-up regime, where we start with 75 IU in a normal BMI patient. If the patient is thin and if we anticipate multifollicular development or hyper response, as in case of severe PCO, we can start with a lower dose of 37.5 IU. Then we reassess on day 7 or 8, and the dose can be increased according to the follicular response. The other regime is the step down regime. We rarely use. We mostly use the step down protocol in patients with poor response or poor ovarian reserve who wants IUI cycle. So we start with a higher dose of 150 to 225 IU. It's given for 5 days. We reassess. We see the follicular response. If the follicle gets responded, that if it is more than 9 mm, then the dosage is reduced by 37.5 IU every 3 days, and the final dose is with 75 IU. It is continued till the day of HCG. If there is no response, then we increase the dose by 37.5. It is continued for 10 days, and the response is reassessed after 10 days. If hyper response is noted or poor response is noted, we cancel the cycle. Coming to the final thing, oral ovulogens and gonadotropin, which is my most favorite one. Here we give clomiphene citrate or letrozole from day 2 to day 6. We assess the follicular response on day 7, and we add gonadotropin from day 7 and reassess every 3 days, and additional doses are added if needed. GnRH antagonist can also be added, and it prevents LH surge and it lowers the rate of OHSS. The most common protocol we use is Lübeck protocol, where the antagonist, that is Cyscure or Cetrolix, which is available in the market in a dose of 250 microgram when dominant follicle reaches 14 mm, and it is continued till the day of HCG. The other protocol is French protocol, where a single dose antagonist is added, which we are not following. What are all the problems that can be encountered while using ovulation induction? There can be poor or no response to ovulation induction, hyperstimulation, luteinized unruptured follicle can be there, and thin endometrium, particularly when using CC. What can be done if hyper response is there? We should consider cycle cancellation if we see more than four follicles of more than 15 in diameter, or more than 2 follicle of more than 16 millimeter, and more than 2 follicle of more than 14 millimeter. Irrespective of the E2 cycle, it is better to cancel the cycle. And if E2 level are more than 1500, avoid giving trigger, advise abstinence to the patient. If the patient still wants to continue the cycle, rescue IVF can be considered after proper counseling. As we can see, the pregnancy rate increases with 3 follicles, and after 4 or more follicles, the rate actually decreases. Coming to the trigger, the ovulation trigger is given when the leading follicle reaches 18 to 20 mm, and cycle cancellation is considered if hyper response is noted. Usually the trigger we give is HCG at a dose of 5000 to 10,000 IU. Recombinant HCG at a dose of 250 corresponding to 6500 IU can also be used. GnRH agonist trigger can also be used, but if agonist trigger is given, luteal support is mandatory. As most of us are now setting up IUI lab, I wanted to touch few points. According to ART law, the minimum staff requirement is 1 gynecologist and 1 counselor. But in the revised version, they say only a gynecologist is needed, who can also act as a counselor. Coming to the equipments, these are all the equipments listed in the initial law: a laboratory centrifuge, benchtop autoclave, ultrasound machine, laminar or airflow, microscope, incubator, semen wash processing facility, refrigerator. But in the revised version, centrifuge, ultrasound machine, microscope, semen wash processing facility, and refrigerator is enough. Laminar, airflow, incubator, and autoclave are optional, but the appropriate authority is expecting us to show the laminar airflow while coming for inspection. Coming to the layout, there should be a reception and waiting area. There should be a consulting room, a semen collection room separately, a semen processing lab, a IUI room, a record room or counselor room, and an ultrasound room. And regarding semen collection, the patient is advised to have 3 to 5 days abstinence, and it is collected by masturbation in a clean, sterile container. No home collection is entertained. If at all the patient needs home collection, after proper consents, he should allow to bring the home collection sample, and the sample should reach the clinic within 20 minutes. And difficulty in collection can be encountered in patients with situational anejaculation and total anejaculation, which can be on an orgasmic or orgasmic, as in case of retrograde anejaculation. How to manage the collection problem? They can try coitus interruptus, and the sample should be collected in a non-spermicidal condom, and no direct sample is preferred as it can be mixed with vaginal secretion. In anejaculation, in orgasmic anejaculation, vibrated therapy or electroejaculation can be considered. In stress-induced failure, as in case of situational anejaculation, prior freezing of the sample can be considered. In cases of orgasmic anejaculation, that is retrograde ejaculation, sperms can be retrieved from urine. How this can be done? The patient is given anticholinergic and sympathomimetic drug for a week. And then on the day of sample collection, the patient is asked to empty the bladder, and after masturbation, 2 containers are given. In the first container, the ejaculate is collected, and then the second container, the post-ejaculate urine sample is collected. Sperms can be retrieved from urine. Coming to semen preparation, the goal of semen preparation is to remove the seminal fluid from the sperms, as the seminal fluid contain all the impurities and the prostaglandins, which may induce uterine cramps and at times can also cause severe allergic reactions to the women. So also the motile sperm is separated from the immotile and the abnormal sperms. The presence of immotile and the abnormal sperms is going to increase 10 to 15 times the reactive oxygen species in the sample. So thereby increasing the oxidative stress to the normal sperms. So these are all the preparation techniques we commonly use: the simple wash, the direct swim up technique, the density gradient, the pellet and swim up technique. The first one, simple wash, can be used only for preparing samples for IUI. The other three can be used for preparing samples for ICSI. And coming to simple wash, the simple wash is the preferred method when the count is very low, as centrifugation with higher force may cause damage to the sperms when the count is low. Almost 90 to 95% of motile sperms can be retrieved, but a lot of debris and cells can also be included in the pellet. How to prepare a simple wash? It is very easy. We have to take a 15 ml of 15 ml centrifuge test tube. In that, around 0.5 ml to 1 ml of the semen sample is taken, and it is suspended with 10 ml of wash media, and it is centrifuged for 10 minutes. After centrifugation, we take the tube and we can see the pellet at the bottom of the tube. The top supernatant is removed. Again, the pellet is resuspended with wash media, and again it is centrifuged. 2 to 3 times centrifugation can be used in simple wash, and the final pellet, which is collected at the bottom of the tube, is suspended with 0.5 to 0.7 ml of the media, which becomes the IUI sample. Coming to the next technique, the swim up technique. This is based on the concept that the motile sperms tend to move towards the topmost layer. So here the initial steps are like that of the simple wash. First, we mix with the wash media. One centrifugation is done as in simple wash, and we collect the pellet. This first pellet is mixed with wash media to make a sample of with a concentration of 20 million sperms per ml. This sample is then again split into multiple tubes, placing 0.5 ml of the sample in each tube. To this 0.5 ml, we add 1 ml of wash media over this. Slowly it is laid over the sample, and all these tubes are incubated for 1 hour at 37 degrees Celsius at an angle of 45 degrees. After 1 hour incubation, if we take, we can see the motile sperms at the supernatant layer, and this supernatant layer is taken, and it is again mixed with the wash media, and a final centrifugation is done, which gives an excellent pellet of motile sperm at the bottom. And this pellet is taken and mixed with 0.5 ml of the media to become a UV sample. Next is the density gradient technique, which we most commonly used, which gives the more motile sperm concentrate. This is based on the concept that the motile sperms, being denser, has the tendency to move towards the denser fluid. Here we take two density gradient media. One is 90% and another one is 40% strength. So most of us, we get 100% stock solution. So how to make 90% density gradient media is, from this 100% solution, we take 9 ml and mix 1 ml of the wash media, and this becomes the 90% density gradient media. And to form 45% strength media, we take 5 ml from this 90% media and add 5 ml of the wash media, and this forms the 45% density gradient solution. So in a tube, first we place the denser media at the bottom. 1 ml of 90% density gradient media is placed at the bottom, and over that 1 ml of 45% media is placed, and over that around 0.5 to 1 ml of the semen sample is slowly laid down. In density gradient technique, only 2 centrifugations are done. The first is done for 20 minutes at a greater force. After centrifugation, we can see the pellet settling down at the bottom. This pellet is taken and then it is mixed with 4 ml of wash media and subjected to another centrifugation, which results in a beautiful motile sperm pellet at the bottom. This is taken and reconstituted to form the IUI sample. So this is the video showing how to prepare the semen sample with density gradient as well as swim up. So first the centrifuge tube is taken, and we take first 90% density gradient media, and then we place it at the bottom. Here they have taken 80% and 40% gradient media. So the denser media is placed at the bottom of the tube, as we can see, and followed by which we take 40% media and it is slowly laid over the 90-80% media. We can see the color difference, the difference between the densities, and to that the sample is taken and around 0.5 to 1 ml of sample is slowly laid over. It should be centrifuged for 15 to 20 minutes. So after centrifugation, we can see the pellet at the bottom of the tube. The supernatant are removed, and also the upper layer of the 90% media is also removed, so that we get a good concentrate of the sperms. This is taken in a separate tube. So we take another separate tube. We add the wash media. Around 4 ml of the wash media is taken, and to that the pellet which we have formed is taken and it is gradually mixed with the wash media, as we can see. So it's gently mixed, and this is again subjected to centrifugation. So only 2 centrifugation is done in density gradient technique. So it is done, the second centrifugation is done for 5 to 10 minutes. So after this, we can see the beautiful pellet. So the thick white color is the pellet of motile sperms, and the supernatant is removed. And here we do pellet with swim up. So this gives the excellent sample. So this pellet is again taken and it is mixed and it is placed within the wash media by underlay technique. Here we are doing underlay technique. We are laying the pellet at the bottom of the tube, and this is incubated at 45 degrees and 37 degrees Celsius, 45-degree angle it should be placed, and it is incubated for 30 minutes. So the final sample, it is taken and it can be directly used as the IUI sample. Coming to the cannula should be easy to use. It should be semi-rigid and it should be made up of non-toxic material and rounded tip to minimize trauma, and it should be properly washed and sterilized. And most commonly we use the soft catheter. And coming to quality, the quality of the sample is good if the post-wash total motile sperm concentration is more than 10 million. Also, good results can be expected if the post-wash total motile sperm concentrate is more than 4 million also. Coming to the quantity, we load the prepared semen sample in a 1 ml syringe. Around 0.6 to 1 ml max is inseminated. Practical tips for IUI: plan IUI around the time of ovulation. Use non-toxic, non-powdered gloves. Do not hold the cervix. Just expose it with cuscose bivalve speculum. Excess mucus, if any, can be removed by cotton swab. Inseminate the processed sample of about 0.3 to 0.5 ml, just 2 cm above the internal os and 1 to 2 cm from the fundus. Inseminate slowly over 60 to 90 seconds to prevent reflux, and keep the catheter for 60 more seconds and remove it gently. Ask the patient to rest there for 10 to 15 minutes. What can be done when you encounter difficulty in IUI? Partially filled bladder may help in acutely anteverted uterus. Gentle cervical traction with an alley and stim speculum can help in straightening out the internal os. A stillet can be used under ultrasound guidance if we encounter difficulty in negotiating. Pregnancy test is usually done after 14 to 16 days. So this is the video showing how we use a stillet. So here, while negotiating the internal os, I find it difficult. So this is the stillet. So this stillet can be used under ultrasound guidance to negotiate the difficult internal os. So this is a plastic stillet we use. And after entering the internal os, we remove the stillet and we take the syringe with the loaded sample, and the sample is slow and steadily, it is injected into the uterine cavity. After injecting, the catheter is kept for 60 more seconds and then removed gently. Coming to the luteal support, it is definitely beneficial, which is going to be dealt with the next speaker. So finally, what is the ESHRE consensus on IUI? So coming to the indications, IUI can be considered as first line treatment for patients with unexplained infertility. And IUI combined with ovulation stimulation definitely improves live birth rate in couple with unexplained infertility. Coming to the timing of insemination, in when HCG is used, a single IUI can be performed any time between 24 to 40 hours after HCG injection. In natural cycles, IUI can be done 1 day after the LH rise. Coming to the optimal number of insemination, there is insufficient evidence to support double IUI over single IUI. Coming to bed rest after IUI, 10 to 15 minutes of rest after insemination is enough. They can have normal day-to-day activities. And coming to the number of consecutive IUI cycle, at least 3 consecutive IUI cycles should be performed. Estre suggests considering the next mode of treatment if 3 consecutive IUI cycles gets failed, but still there is insufficient evidence to recommend a maximum number of IUI treatment cycle. Coming to the semen preparation technique, it is not possible to recommend any semen preparation technique over another. Whichever is comfortable with your endo technician and whichever is comfortable with your clinic, we can use that. Coming to prevent multiple pregnancies, consider cycle cancellation if hyper response is anticipated. So this is substantiated in the recent ISHRAE 2023 guidelines on unexplained infertility, that IUI with ovarian stimulation is recommended as a first-line treatment for couple with unexplained infertility. And to avoid multiple pregnancies and OHSS, care is needed by using gonadotropin treatment only in a low dose regimen with adequate monitoring. IVF is probably not recommended over IUI with ovarian stimulation in couples with unexplained infertility. So thank you IFS Society for giving me this wonderful opportunity to present this topic in a wide platform. Thank you so much.
Thank you, Charanya. That was very good. Thank you. Anyway, I will initiate questions. Probably those who have questions, they can put it on the chat box and you can answer. See, you were talking about CC dose up to 250. Don't you think anti-estrogenic effect would be high?
That is FDA approved dose, ma'am, but we are not using more than 150 gram per day, ma'am.
That's what I think. Don't go beyond 150 because if you go beyond 150, definitely the anti-estrogenic effect of clomiphene will be very high, and whatever we wanted to achieve may not be there. So that was one thing I wanted to say. And other thing is that retrograde ejaculation.
Yes, ma'am.
Will you advise alkalinization of the urine as well? Will you ask them to take some citral alcohol?
Yeah, alkalinization of the urine can be considered. We can ask the patient to have sodium bicarbonate and the day before and 1 to 2 hours before the procedure. But the only difficulty with that is the patient should not have a lot of water, because if they take a lot of water, again it is going to increase the volume of the urine. But in this era of IVF and ICSI, retrograde ejaculation, we usually go with ICSI.
But then we have to complete whenever we give an insight into whatever we are talking. So I just thought I should bring in that. And do you think centrifugation, the number of times that you do centrifuge or the resolutions that you give, does it really interfere with the sperm quality?
That's what in density gradient, it is only 2 centrifugation. In simple wash also, the centrifugation time is very minimal. So what simple wash gives higher retrieval of motile sperms, but we get the more progressive motile sperm concentrate with the density gradient.
That's true. That's what. And do you think there are any special situations where you want to go for a second sitting IUI? In the same cycle, you do 2 IUIs. We know that the results doesn't improve, but will you recommend for any special situation?
Ma'am, in repeated IUI failure or when the count is very low, we use pooled samples also at times. We ask the patient to give 2 samples on the same day. We use pooled sample. In repeated unexplained IUI failure or when we cannot time the ovulation, at times we may see the follicle developing at day 15 or day 16. So at that time we can try double IUI also. But
pooled sample, especially when you know that the volume is very low, when you know beforehand it's that the quality of the sperm is not good, all that we would ask for a pooled sample. Otherwise, on a routine basis, when you call the patient for IUI, and today you have timed your IUI and all that, And today the sample has been very average. Usually we say the second sample is always better. So in case you think today it was not good, will you call them for the next day for an IUI as well?
Ma'am, that day itself actually that the same day the second sample is actually good.
Okay,
And
that's what.
and
That's
I
what. Maybe
usually advise the patient when I start induction for IUI, I ask the husband to ejaculate once in 2 days. So in such cases, the sample is actually good, ma'am.
you said abstinence of 3 to 5 days. Do you ask them to abstain for 3 days before they
No,
come for
ma'am, I
IUI?
actually ask the patient, in my clinic, I ask the patient to ejaculate every 2 to 3 days. So that is mandatory, so that on the day of IUI, the sample is actually very good. Also, sometimes the patient's DFI also can be high. In such cases, also this repeated
That's
ejaculation
what.
is helpful.
Tamilnadu, what will you do?
Yes, ma'am. I ask them to have regular intercourse on alternate days. That is even more beneficial. And I always tell them to have only 1 day of abstinence, ma'am. Because when we leave so many days of abstinence, the number of immotile sperms become
Sperms will be higher.
higher.
That's what we do not know whether they are dead sperms or immotile sperms. So
Immotile
even I ask them to have intercourse on the day we give HCG. The
yes.
next day I go ask them to go on abstinence and come the next day for IUI. That's how even I do. That's what I just wanted to.
Immortality comes down. At least whatever
Because
number of sperms we get will be good and motile.
that will be better because we'll have a good sample on the day when we are planning to do an IUI.
Yes.
So I thought I'll just add on these points to that. Good, very nice, Saranya. Thank you very much. And I really thank you for accepting to be a speaker as soon as I called you.
Thank
That
you
was
so
the
much.
best. I look forward for young doctors to do this because only then you all will come to the limelight. So I thank you really. Thank you very much.
Thank you.
Any doubts from the delegates? You just put it on the chat box. We can discuss it again also after Tamilchelvi finishes. So now I think we'll move on to Tamilchelvi.
Yes.
Dr. Tamilchelvi has finished her fellowship in reproductive medicine from CIMAR, and she's a young dynamic doctor at Trichy. Because I know her very well, I can even go without the slide about her. She has presented several papers in ASUOG, UA, Foxy, National ISAR, World Vision, etc. She's a very enthusiastic person, and so she was interested in, accepting this talk as soon as I asked her. Thank you, Tamilchelvi. Let's hear how she will support the luteal phase after an IUI. Thank you.
Thank you
Go
for
on.
the kind words, ma'am. At this outset, I would like to thank Dr. Ramni ma'am and Dr. Chitra ma'am for giving me this opportunity. I also thank the IFS Society. Can you see the screen, ma'am? My topic for today is luteal phase support.
Double click on the slide, ma.
Yes. Yes. So in this talk, I'll try to cover about luteal phase support, luteal phase defect, and how do we give luteal phase support in IUI, and what are the drugs used, and what is the evidence for luteal phase support. So let's look into a little of physiology before moving on to luteal phase support. So this is the graph we have seen since our physiology days, and now Dr. Saranya has dealt with what we do during this follicular phase. And now moving on to the luteal phase. Once the ovulation has occurred, the granulosa and the theca cells start to become luteinized. Meaning neovascularization happens and the LDL molecules come and get settled inside the corpus granulosa cells and the theca lutein cells, and they start secreting the progesterone. And how does it happen is we actually have an inherent LH pulsatile LH secretion in a pulsatile manner, and this supports the steroidogenesis inside the corpus luteum, and this results in a pulsatile progesterone secretion, and this helps in the secretory pattern of the endometrium. Along with progesterone, the corpus luteum also secretes inhibin A, a little of estrogen and relaxin. All these hormones together, they increase the endometrial receptivity. They turn the endometrium into a secretory pattern, and they do immunomodulation in the endometrium, and this endometrium becomes more receptive to the growing embryo. So this is the normal physiology I talked about. So LH support is LH support, endogenous LH secretion in a pulsatile manner is required for corpus luteal function, and this maintains the corpus luteum and prevents the corpus luteum from undergoing apoptosis and autophagy. And till as we know, the normal luteal phase typically lasts for 14 days plus or minus 2 days, means the range is from 12 to 16 days. So this once by the end of 14 days, when there is a HCG secreted by the embryo, the corpus luteum is again rescued and it continues to support the pregnancy till the placenta takes over. So this corpus luteum also has effects on the endometrium. As I said, it causes secretory transformation, increases the receptivity of the endometrium, and causes immunomodulation of the endometrium. So what can happen? What is the problem that can happen in this luteal support is common defect we see is the luteal phase defect. What does that mean? It is the presence of short luteal phase. That is when the luteal phase from the day of documentation of ovulation, when the patient is getting her menses within 10 days, usually it can last between 9 to 11 days. When the typical luteal phase duration is less than 12 days. Usually we call it short luteal phase, and this is the reason for luteal phase defect. And why does it happen? It may be because of the defect in the pulsatile secretion of the LH or inadequate progesterone exposure, inadequate progesterone secretion by the corpus luteum, resulting in inadequate progesterone exposure to the endometrium. So common etiologies are mainly the follicle that has grown, the Graafian follicle, the dominant follicle that was not of a good quality. And other thing is corpus luteal insufficiency, where there is a inadequate LH secretion followed by inadequate progesterone support. Also, when the endometrium is not that receptive, even though the corpus luteum is functioning well and is secreting all inhibin, relaxin, progesterone, everything, but the endometrium is not ready to receive any of the things and is not receptive. This also results in a luteal phase defect. So, does it occur only in infertile patients? No. Studies have documented that luteal phase defect can also occur in a fertile patient, normally menstruating patient, in occasional cycles. So, is luteal phase defect a sole contributor for infertility? No. There are no studies that say that luteal phase defect causes infertility in any of the patients, or it doesn't cause recurrent pregnancy loss in any infertile patients. So, it is just a added problem, but that doesn't cause any of the individual problems that happens in all infertile patients. So the clinical relevance of luteal phase defect is actually debatable. So this is the luteal phase defect I talked about. Normally, when the luteal phase lasts for 14 days, which within a range of 12 to 16 days, in case of luteal phase defect, it lasts less than 11 days. So what are all the causes of luteal phase defect? It may be because of the egg. The follicular genesis was defective, or there is an unruptured follicle, unruptured luteinized follicle. Because of that, it can be this can cause luteal phase defect. When the patient has severe anorexia, or she is doing severe forms of exercise, and when there is endometriosis, PCOS, or she is morbidly obese, or when there are metabolic disorders like thyroid dysfunction or hyperprolactinemia, all these can cause luteal phase defect. So when we see a patient with typical shortening of the luteal phase, try to look into these factors. If there are any of these things, try to correct them. So short luteal phase will automatically get corrected. So as I said, the short luteal phase is typically less than 10 days. So it can range between 9 to 11 days. And this as per the history, when we ask the patient, when she says shortening of cycles, it is suggestive of luteal phase. And to clinically detect it, there are few studies that suggest we can do a mid-luteal serum progesterone. But the problem with the mid-luteal serum progesterone value is progesterone is getting secreted in a pulsatile manner in our body in response to the pulsatile secretion of LH. So the peak and the trough and the next peak usually occurs within every 90 minutes in our body. So the timing of progesterone value measurement, it can be during the trough period or the peak period. We really don't know, and it varies usually. So it is not a very good test to look for the presence of luteal phase defect. But what can be done is within a period of 4 days, say from the day of ovulation, we start doing progesterone levels on 3 various occasions. Between 5th and 9th day of ovulation, we take 3 progesterone measurements and we add all of them. And if the value is above 35 nanogram per ml, we say that there is no luteal phase defect. But can we do endometrial dating to know that she has a luteal phase defect? No, it is not recommended. Endometrial dating is just to know that whether it is a follicular or luteal phase endometrium, that's all. But we cannot diagnose luteal phase defect with endometrial dating. So what does ASRM say? There is no diagnostic test for luteal phase defect that has been proven to be reliable in the clinical settings. So what do we, how do we go about luteal phase defect? How do we support the luteal phase in the patients? So always to know if she has luteal phase defect, first confirm her ovulation by accurately looking for the LH surge and confirming the ovulation with the help of ultrasound. Never do routine biopsy to diagnose luteal phase defect. Also, try to correct the underlying conditions like any thyroid disorder, hyperprolactinemia, correct her BMI, and if she's really doing intense exercises, ask her to moderate the amount of exercise she is doing. So how do we give luteal support in IUI cycles? Luteal support is preferably very much beneficial in case of IVF cycles. The usage of IUI, luteal phase support in IUI is controversial. Many studies and meta-analysis has been conducted and has been published in Cochrane and the endocrinology journals. They all say that there is uncertain evidence regarding luteal phase support in IUI. So what are all the drugs that can be used during luteal phase support? Most common drug that is used is progesterone, followed by estrogen, HCG, and GnRH agonist. We'll see about them one by one. So the first drug we talk about is progesterone. The most common form that can be used is vaginal micronized progesterone, and the usual dosage is 200 to 400 milligram per day in divided doses. We can also go with the usage of oral dydrogesterone when the patient is not very compliant or she is not very comfortable with the use of vaginal progesterone. Oral dydrogesterone typically we give in a dosage of 20 to 30 milligram in divided doses, or we can even combine oral dydrogesterone and vaginal progesterone. But this protocol is usually given for IVF rather than IUI patients. Also, if the patient is not able to use vaginal progesterone, or if she is not tolerant to oral progesterone, rarely we can go for injectable progesterones. Common preparations can be given as IM or subcutaneous progesterone, but IUI, the use of injectable progesterone is very limited. So usually we start progesterone typically from 48 hours following ovulation. 48 hours following trigger. Some studies say that we can even use 48 hours following ovulation. And once pregnancy is confirmed, the luteal phase support has to be continued till 10 to 12 weeks of pregnancy till the placenta takes over. So what are all the pros and cons? Progesterone is the most reliable form of luteal phase support that can be given because this is more physiologically available in our body and it goes and does its job properly by maintaining the corpus luteum. But many RCTs and meta-analysis signals the doubts the benefit of usage of progesterone and stimulated IUI, and they say there is no proper evidence to use progesterone in IUI because of the heterogeneity of many studies that had been published for the meta-analysis. And Cochrane says that there is uncertain benefit in of usage of progesterone in natural cycles. How about estrogen? Estrogen is usually not added in IUI cycles. The rationale behind the usage of estrogen is it stabilizes the endometrium, upregulates the progesterone receptors, and helps to maintain the receptivity of the endometrium. But usually we don't use estrogen in case of IUI cycles. Estrogen is mostly used in case of IVF cycles. If at all we had started using estrogen in case of thin endometrium, we continue to use during luteal phase also. What about HCG? HCG is one of the physiological form that easily supports the corpus luteum, because once, even if you are not going to give any luteal support, once the fertilization happens, the embryo is going to secrete HCG, and this HCG maintains the corpus luteum. Corpus luteum is rescued by the HCG secreted by the embryo. So even if you are going to give HCG from outside, this is the most physiological form of luteal support that can be given, and it is very simple. As much as low as 1,500 international units of HCG can also be given to support the corpus luteum. But only thing is, in case of hyper-responders, there is a very high risk of OHSs, and we try to avoid in hyper-responders. And also in case of multifollicular stimulation, we try to avoid the usage of HCG. How about GnRH agonist? GnRH agonist as a luteal phase support agent is also not recommended in case of IUI, but IVF GnRH agonist is being used once in 2 days, like how we get it inside our body in a pulsatile manner. This is also used once in 2 days in case of IVF, but its role is very much limited in IUI. So let's see how we can use with different kinds of stimulation. What's the protocol that is being recommended? In case of clomiphene alone stimulated IUI, they suggest, many studies suggest that vaginal micronized progesterone 200 milligram at night is more than enough to maintain the corpus luteum. And also we have to tell the patient about the uncertainty of using all these luteal support, because when they think a luteal phase defect is the only problem causing infertility, and when we are going to support it with luteal phase drugs, they'll be expecting pregnancy they'll be expecting pregnancy more, but we have to tell them it is just going to add to the support, and it is not a confirmatory thing to cause pregnancy. And in case of letrozole stimulated IUI, studies say that both vaginal and oral progesterones can be given. If at all we are going to use dydrogesterone, it should be used at a dosage of minimum of 10 milligram BID from 48 hours from the day of trigger. That is from the day of ovulation or IUI. We have to start giving dydrogesterone from the night of IUI. So evidence suggests that usage of dydrogesterone or any progesterone improves live birth rate in case of letrozole stimulated IUI. In case of gonadotropin stimulated IUI also, they say that progesterone supplementation actually help with the increase in the clinical pregnancy rate. Why? Because whenever we use gonadotrophins, there will be multifollicular stimulation, and these multifollicles will be giving more of estrogen, and the concept is that this estrogen is going to inhibit the LH, and the pulsatility of LH actually comes down. So because of this, the corpus luteal lysis is going to happen. So when we are going to supplement with progesterone, it helps a lot in case of gonadotropin stimulated IUI. So commonly recommended progesterone is vaginal 200 milligram BD from the night of IUI, or if the patient is not tolerating the vaginal progesterone, go ahead with oral dydrogesterone 10 milligram BD from the night of IUI. So we are going to continue till her beta HCG becomes positive, later also till 10 to 12 weeks of pregnancy. So how are we going to use, just like that, are we going to give vaginal progesterone for all patients or dydrogesterone for all patients, or are we going to individualize the luteal phase support depending on each patient's profile? In case of IVF, we usually go for individualized treatment, meaning depending on her BMI, depending on her tolerability, how her previous response had been, we modify the luteal phase support. But in case of IUA, studies say that generalized luteal phase support is works fairly well. So you can just fix a protocol and give for all patients. Sometimes if the patient is not tolerating a specific form of progesterone, you can change her into other form. So what does the systematic review say? So there is a study in endocrinology journal in 2022 that concluded that there is increased clinical pregnancy or live birth rate after ovulation induction and IUA. And it is strongest in case of gonadotrophin stimulated cycles. So when we are going to give luteal phase support, it works very well in gonadotrophin stimulated cycles, and it is very much essential. Whereas Cochrane said that there is low certainty evidence that progesterone may increase clinical pregnancy or live birth rate, because the studies that had been analyzed, the heterogeneity was high. And Reproductive Biomed Online said that oral progesterone improved live birth rate in electrostimulated cycle. So, though there are variable outcomes, but general opinion is that luteal phase support in some form gives a positive result. So, as I said, Cochrane concluded saying that we are uncertain if vaginal progesterone supplementation increases live birth or ongoing pregnancy, and more studies are required. And also, when we are going to mark a patient as having luteal phase defect, we cannot just tell her that this is a magic masala and this is going to work on her and she is going to definitely become pregnant. It doesn't work like that. We have to tell her that because she has some inherent problem in her body and we are going to supplement it, and this is going to just add to the possibility of becoming pregnant. And this is not a 100% sure thing that she will become pregnant in the same cycle. Just discussion about everything and usage of patient preference, considering patient's preference, the cost, the tolerability of the patient, and usage of the protocol as per their opinion also is important. And also avoid HCG in high responders. Discuss about OHS risk if you are going to use HCG. So what are all the take-home messages? There is uncertainty regarding the use of luteal phase support in IUA as per Cochrane. Progesterone luteal phase support is reasonable in stimulated IUA. Estrogen add-on not routinely beneficial. HCG increases OHS risk in high responders. Individualized regimens if required. Prioritize safety and patient-centered care. Thank you.
Thank you, Tamilnadu. I
Thank
think
you,
even at the first most, when we start off with any stimulation itself, ovulation induction, I think we have to talk to them about OHSS. Because
Yes.
nowadays, especially, when you talk about emergency, shift, rescue IVF and other things, it's better that we tell them that you can have one, two, multiple follicles, anything in your thing. What will be your response to this drug? I really do not know. So you have to anticipate everything. And you have to tell them that if they are willing for that, then only take them up for even an IUA stimulation. So this all this we have learned through the hard way. But I think all of you should be very clear in the way you communicate to all the patients, because it's very tough these days. It's very tough. You have to tell them what you would expect out of each response. Okay. Tamilnadu, do you think, really the multifollicular development that happens during the ovulation induction or the trigger that you use make you feel that you require the luteal phase?
Yes, ma'am. Both are there. Multifollicular development is through one mechanism, whereas the GnRH agonist trigger, what we give, usually the natural LH surge, it lasts for 36 hours and then again progesterone rises slowly. So there is no gap in between the hormones. Whereas in case of GnRH trigger, it just works for maximum of 24 hours. So there is a gap before the progesterone takes over, and that's where the corpus luteum starts to lyse sometimes. We really don't know. But whereas when we give HCG, it works for 5 days. So even if the progesterone rises slowly, that will maintain the corpus luteum. So there is a defect in case of GnRH agonist trigger. So better start from 48 hours. because even if there is a small gap of 24 hours, corpus luteum doesn't undergo lysis within that phase. When we start with progesterone from 48 hours from the trigger, it is enough now, more than enough. But we have to support with more dosage of progesterone in case of GnRH agonist trigger compared to HCG trigger. Because
would you like to add estrogen as well?
IUI cycles, I don't give estrogen, ma'am. If,
But then when thin endometrium is there, you said you will give
in
estrogen.
endometrium, if I have started estrogen, I continue to use.
The same dose or you'll reduce?
Usually I start with BD dosage. If I had gone for TDS, I'll again convert to BD because very less amount of estrogen only is required in the luteal phase. So need not give TID or QID, ma'am.
And the progesterone should be always more than the estrogen. So you
Yes.
want to make that also lesser.
Yes.
Charanya, any comment on that? Charanya, are you here? Are you here? Do you give estrogen during the luteal support?
Ma'am, no, if I have started earlier, I used to continue. After trigger, I don't add estrogen, I add progesterone.
Okay.
only.
Do you reduce the dose, whatever you have given before ovulation, or you continue the same dose?
Ma'am,
Suppose you have given TID, Tamilnadu was telling.
if I have
she'll bring
started
it down.
earlier, before the trigger, what is the dose of estrogen? I will continue with the same dose.
Same dose. Okay. She continues with the same. Tamilnadu reduces a little. Okay. I got that. This diagnosis of LPD can be even with the history itself. Suppose
Yes.
patient tells you that she has a very short cycle.
Short cycle.
I personally, I think you should do one cycle without any ovulation induction.
Yes.
And
Look for
see really
ovulation.
if that
Yeah.
cycle is really short.
Short.
Then you understand for yourself when your ovulation trigger will work also. Like
Yes.
when you will expect the follicle to really mature.
Grow.
Because for some it is on 10th day, some it's on 11th day, some it's on the 14th day.
14th day.
So they say that cycle is 20. I get regular cycles. That's the only statement they will give us. But
Yes.
really when you ask for whether the cycle is 24 days or it is 28 days, it gives you that little bit of extra information that you will expect ovulation to occur on 11th day or 10th day or on the 14th day.
14th
So
day.
you can, spend a little more time on that and take that history so that we benefit out of that. Charanya, there was one question on the chat box asking you about, IUI after ovulation. So I think you missed on that, the timing of IUI.
I usually prefer doing IUI between 34 to 40 hours after trigger. I don't wait beyond 40 hours. Because the inseminated sample again, it has to reach the oocyte, it takes time, so I don't wait beyond 40 hours.
Okay.
Even if it is ruptured or unruptured, I do it with between that time.
That's what they say, 38 hours, the results are the maximum. So you can do it at 36 hours or at 40 hours, but don't go beyond 40 hours. That's it. So do you check for follicle rupture after you have done an IUI?
For IUI, I don't check for rupture, ma'am. If I'm doing double IUI, I do at 2 consecutive days. So at that time, after rupture one IUI, but in case of single IUI, if follicle rupture is not documented, I don't repeat scan to assess rupture usually.
All of you are very fond of this Doppler studies and follicular study. Dopplers and follicular study. Do you do a Doppler in all IUI time according to that? Do you look for corpus luteal flow before you decide on support? Tamilnadu, do you do Doppler and then decide whether you require luteal support, or do you time your IUI based on the PSV that you see on the follicle?
Yes, ma'am. For IUI, I do. But normal cycles, I just ask them to have intercourse.
Okay, no, for all IUI, you go with PSV. You will check the
Yes,
PSV and then only give the trigger.
Yes, ma'am. Yes.
So you will wait for about 10 to give the trigger.
Yes, ma'am. Yes.
Saranya, you?
Ma'am, I don't routinely see Doppler, ma'am. I see the follicle size and the follicle will pop off and it will look brighter if it has a good oocyte, and usually the endometrium will be excellent triple line. So if I see that, I am very sure about the success.
And there is a lot of, a lot of controversies about the size when you expect it to rupture. Flocomifene, they say it's one size. For letrozole, they say it's another size. For gonadotropin, they say another size. So when will you decide when to give the trigger?
Ma'am, if I use gonadotropin, 18 mm is also okay. If I use CC, at times I will wait till 22 mm also.
Okay.
For letrozole, between 18 to 20 mm, I usually give trigger. But most of the time, I prefer the 20 mm size, ma'am. And I always correlate with the triple line endometrium. That echogenicity of that endometrium gives the hint.
Okay. So will you add estrogen anytime during the follicular phase? When you don't see that there is a disparity between the endometrium and the follicle size, will you add endogenous estrogen?
Ma'am, I always add estrogen after dominant follicle only. At least
That is on day 7.
yes, ma'am. At least I will wait till 16 mm, ma'am, because if if I start before estrogen, it suppresses the growth of the follicle. So I have seen. So I usually wait until at least 16 mm to start estrogen.
See, we say 2 millimeter size, it will grow each day.
Yes,
So
ma'am.
suppose it's 16 today, tomorrow it's going to be 18. And day after tomorrow it's going to be 20. For you, it's ready for trigger for day after tomorrow. Okay.
Yes,
but then your estrogen, suppose your ER is only 6 today.
Ma'am, ma'am, that's what from 14 mm I will correlate the synchronicity. If I am starting earlier, I will start with the low dose. If I am starting with 16 mm, still it is only 6 mm. It start with the higher dose of estrogen. I will start with the TDS dose, 2 mg 1 TDS dose.
Okay. Okay. Thank you very much. Anything else that you all would like to add? No, I think I have done also with whatever I noted down. Okay. Thank you very much. Both of you all were extremely good. Thank you. I hope the delegates enjoyed and got whatever information they would like to gather out of it. Just a minute. I have a few things on the chat. Can we give trigger if the endometrial vascularity? Endometrial vascularity is there, but the ET thickness is only 7.
7 is okay, ma'am.
In such cases, I will wait till the size 22 mm also. I will add estrogen and wait for 1 more day.
Okay. Okay. And again, it depends on whether the patient was on estrogen, because estrogen only would probably bring the endometrium thin and the gonadotropin will not. So gonadotropin, if your follicle is 18, 19 itself, your endometrium will be decent. It will be 8, 9, 10, anything that you would want it to be. But when it is clomiphene, you always face this challenge. Have you any time tried letrozole and clomiphene together for ovulation induction?
I haven't
tried in few patients, ma'am. But only 1 conceived, like out of 5.
When will you do that? Will you give letrozole first or clomiphene first, or both together?
Both together for 5 days.
Both
I
together
don't give
for 5 days.
gonadotrophins. I don't give gonadotrophins. Just for
Okay.
5 days. Wait for 5 more days.
Why you give both? For the benefit of the audience. Why do you give both?
It works well in case of poor responders, ma'am. When we
Both of them work in a different mechanism. You tell them that. Letrozole works in a different way.
Clomiphene works through central mechanism. It is going to cause feedback. Yes, feedback inhibition, so that FSH window is extended. Whereas letrozole is going to act in the ovaries and causes aromatase. It is an aromatase inhibitor. So it works both the mechanism together. So actually, the number of follicles we expect will be little more compared to letrozole alone.
And especially when you think this clomiphene, you give clomiphene, you get only 1 or 2 follicles all the time. And the endometrium is also not matching. At that time, these two together will give sometimes a little bit of miracle. But, though, on the slide, I could see Shavanya saying 3 or 4 follicles, she'll go ahead with IUI. I personally think not more than 2. That is what has been even told on the literature. So when it is beyond 3, if you go and you do and you get a multiple pregnancy, again, they have come to you for a lesser cost treatment and you cannot go for a higher cost pregnancy for them. So we should be sure that we will not cause multiple pregnancies as well. So be sure whatever stimulation that you give is also efficient enough for an IUI and not cause a OHSS. That we should be sure. Anyway, thank you very much. I hope everybody enjoyed it. And I thank Shield Sagati for always being with me for all these IFS webinars. And I have enjoyed thoroughly today. I hope the others too have enjoyed it. I again thank Tamilchelvi and Charanya for
Thank you.
accepting it immediately and being with us today. Thank you.
Thank you so much.
Thank you, ma'am. Thank you.
Thank you, Sagati. I think we'll log off the meeting. Thank you.